Well, we're going to try and cover some of the indications and results of both forms of stereotactic radiotherapy for pituitary tumors. And at least at UCLA, the first decision whether you use SRS, which is one shot, or radiotherapy, which is traditionally about 27 treatments, is based upon tumor size and location. And for us, it's always location with respect to the chiasm or some part of the optic apparatus, and a tumor that can not be bigger than 3 centimeters. So residual disease like that, if the decision is made to treat, it's a perfect candidate for SRS. You can keep the chiasm dose low, below our traditional cutoff, which came from this single publication in 1993. Not a tremendous number of patients, but as soon as they crossed the 800 centigrade threshold, and that's a maximum point dose, basically 1 pixel above 800 centigrade, they began to experience cases of blindness. So it's not reversible neuropathy, it was permanent. And again, although the numbers are not great, this got in the literature and is pretty much the Bible for radiosurgery. So if you cannot keep the optic apparatus below 800 centigrade, they're no longer a candidate. And then SRT, the fractionated approach, is for all the other patients, those with tumors in excess of 3 centimeters, proximity to the chiasm, or both factors. And these are just some examples from our experience of patients that could not have SRS. And here's kind of the classic patient with disease in the cavernous sinus that is right on the chiasm, and then 2 cases with really gross residual tumor. I probably won't be able to get many more slides like this now that Marvin is here. This is from many, many years ago with a butterfly residual, and then a patient who could not undergo surgery. So these are both bigger than 3 centimeters. And that's because the tolerance of the optic apparatus is fantastic to fractionated radiation. This is a series of quite a few patients that got fractionated radiation to really the entire optic apparatus, meaning chiasm and optic nerves, not just small volumes. But as long as the dose was below about 6,000 centigrade and the dose per day was 180 centigrade, not a single episode of visual tract injury. So that portion of the central nervous system is very tolerant to fractionated radiation. And then what else goes into our thinking is the presentation. So if a non-functional adenoma starts out like that, and Marvin does a great job and leaves just a little bit of that, these patients are observed. We do not radiate incompletely resected non-functionals. They're observed. If they progress, then we radiate them based on, again, volume and location. But if we're presented with that same patient who had a functional adenoma and there is residual disease, we generally go ahead and irradiate them postoperatively without observation. And I think the last case, and what I've learned about these silent corticotroph tumors, would fall into this group because of their natural history. Well, what's our job? So we know who we want to treat. What do we want to accomplish? Well, for a radiation oncologist, the first thing is always tumor control. And we're very good at that. Fantastic. This is a very nice series from the Mayo Clinic, one of the larger single institution experiences of 62 non-functional patients, followed fairly long for adenomas. And you can see the indications. They had a lot of cavernous sinus extension, but were still treatable. Many of them had been followed and had progressed, which is the standard, not to irradiate them immediately. You can see their median size, some of their technical details, 16 gray as the prescription dose. It's a typical gamma knife series. And then they required at least a 2 millimeter shrinkage to be called response. And then this is one of our examples. This is not from the article. This is from our series, patient that could get single fraction radiosurgery. 7-year actuarial control rate is 95%. Tumor response, which is probably important for the patient, note that about 60% will meet the criteria for response. That may not be clinically meaningful, but at least on imaging, there is a response. But about 40% have no change at all over that relatively long follow-up. So benign tumors tend not to respond dramatically to radiation. And then the risk of new endocrine deficits, you can see their numbers, they're relatively low, and the risk is directly related to the size of the lesion. Not so much because of the size of the lesion itself, but because the bigger tumor drags dose to the stalk, and we'll see that in a little bit. But overall, the volume of the tumor is a predictor of needing some type of hormone replacement. Imaging response is slow, very slow, measured in years. Okay, this is one of our patients. This is the pre-radiosurgery image. This is from the planning computer, and this is a 30-month follow-up. So nothing happens quickly, and radiosurgery is no substitute for surgery, at least in terms of mass effect. Tumor morphology does not matter when local control is the issue. This is from a Virginia gamma knife series, and you can see it doesn't matter whether the patient has a micro or macroadenoma, suprasellar extension, or cavernous sinus extension. The control rates are all extremely high. Again, it's control, not response. And if a patient is to develop hormone insufficiency after radiosurgery, the onset is slow, mimicking everything else in the radiotherapy of benign tumors. Median onset of roughly 2 years, meaning long-term follow-up is very necessary. And series that report their results, and we all do it, report their results after 24 to 36 months, probably underestimate the amount of insufficiency that we cause. Okay. How do we avoid endocrinopathy? How do we keep that rate of needing a new hormone low? Well, protect the stalk, and this series proved it. Series from Austria, it's a retrospective review, gamma knife series, and they kept the hypothalamic dose very low, so that was not the issue. Significant difference in the mean stalk dose between those who had new deficiency and those who had no deficiency. Mean stalk dose about 5.5 versus 7.7. Okay? There is some overlap, but our goal always is to keep that stalk dose below about 7 gray. Okay? So our job when it comes time to treatment planning, so here's our tumor. Our job is to find the stalk in red. Of course, you all know that. Chiasm, residual gland, which is not as important. That's not the sensitive structure. But to keep that stalk dose low, in this case, that's the 6.5 gray isodose line.